Welcome, welcome, welcome back, my Be Health Empowered family, to another episode of Excuse Me, Doctor. My name is Dr. Melissa Clark. Of course, please call me Dr. Mel. I am delighted to be back here with you again this week, doing what we always do, which is bringing you evidence based, scientific, factual information to help you make the best health decisions for yourself, your family, and even for your community. If you're newbies to the show, first time tuning in, welcome. We would love if you're listening to us on Facebook to go ahead and click that like button. And if you're joining us on YouTube, please hit that subscribe button. We really appreciate you for it. And if you are veteran watchers, welcome back. And you know that I have to have my fantastic co host with me as I do this every week. So I know you're waiting to see Wayne Bruce and Lila Mays. Welcome, y'all.
In the house. In the house. I can't hear
Fantastic.
Lila. I can't hear Lila. I can't hear Lila. Where's Lila?
Here she
I
is.
said
Here
we
she
took a
is.
couple weeks off, but we back now. Hey, everybody.
Hey,
Wonderful.
what's going
So
on?
yeah, we can get into creating an amazing week for ourselves now that y'all are here. Y'all bring us the word on the street and make sure everybody's voices from the studio are heard. So thank y'all for being here.
Thank
Happy
you
to
for
be
having us.
Absolutely. Now, this is our special Howard University Research Centers and Minority Institutions show. Um,
HU.
HU, we do it every month. We invite Howard University into the studio with us. It's been a great collaboration. They bring wonderful guests who have some relationship to Howard University to help talk about these fantastic topics that we cover. And so I would love to welcome in Karen Parker, who is the project coordinator with the Community Engagement Research Centers and Minority Institutions program. So welcome, Karen. Thanks for joining us.
Thank you for having me once again. Good evening, everybody.
Hi, Karen.
Hi, hi,
Hey, Karen.
hi.
Hey, Karen.
Good to see you. Good to
Hey.
see you,
We're all
everybody.
on caffeine, Karen. So,
You're right.
Yes.
Well, remind
I-
us, Karen, what does RCMI stand for, and what's the Community Engagement Corps?
So, RCMI stands for Research Centers for Minority Institutions. That's the NIH project that we all participate in. That's our program. But CEC, which is my team, is the Community Engagement Corps. So that's the awesome core that has the reach to everybody outside the walls of the Mecca, right? So what we are charged with doing is making sure that the research that is RCMI supported, that is done at Howard, is relevant to our communities and what our community says they need us to take a closer look at. So we do a lot of listening and then a lot of sharing when we have results to share, like tonight. So happy to be
Right.
here and do this with this team.
Which is a revolutionary approach to research, y'all. I just want y'all to know that. Normally it's, the institution tells you what they're doing. This is the opposite. They listen to the community, they bring them in, they focus on what the community finds important. So fantastic.
incredible.
So,
Love it. Best job I've ever had.
yeah, fantastic. So, hey, what are we talking about tonight, y'all?
So listen,
Hmm.
there's Pele, there's Kirstie Alley, Daryl Strawberry, Audrey Hepburn, Eartha Kitt, Tina Turner. Do y'all know what all these people have in common?
All superstars. They
Mm,
superstars.
That's true. Let me add one more. Chadwick Boseman.
Oh, my man.
Yeah.
Mm-hmm.
Did
Forever.
Any guesses?
Did they all have cancer? Like colorectal cancer or
They
past one?
did.
Wow.
That's right.
And
Yeah.
that's why we're wearing blue.
Right. Because that's exactly right. Statistics show that, colorectal cancer was what all these celebrities actually had in common. That was why they died. And even though there are new cases of colorectal cancer actually going down every year, what we do know, for example, with Chadwick Boseman, is that colorectal cancer actually affects Black people out of proportion to our numbers in the population. And it's also being diagnosed in people at younger and younger ages. As a matter of fact, they dropped the age for screening, for starting to screen for colon cancer, to 40 because of this uptick. And it's now the leading cause of cancer death in men under 50 and the second leading cause of death in women under 50. So
Wow.
it's kind of out of control now.
It is out
And
of
so
control.
that's why we thought it was really important to talk about it tonight.
Indeed.
So the reason that we're all wearing blue is that March is Colorectal Cancer Awareness Month, and the advocacy color is blue. And that's what our Excuse Me Doctor episode is this evening. So we're going to collaborate with everyone you see on this call, and we're going to sound the alarm.
Yes.
Right. And so the show today is entitled Straight Talk About Colorectal Cancer. We're going to cover why colorectal cancer is on the rise, why Black people are affected more, how to prevent it, and what you should know if you're trying to navigate the disease. So we have two incredible guests. I'm going to start off with introducing Dr. Adeyinka O.Laiyemo, who's a full professor of medicine at Howard University College of Medicine. He's a gastroenterology specialist, and his research interest is in colorectal cancer prevention and reducing colorectal cancer disparities among vulnerable populations. Welcome, Dr. Laiyemo. Thank you so much for being here with us tonight.
Oh, thank you very much, Dr. Mel. It's truly an honor to be part of your show.
Thank you.
As well, we have Dr. Tracy Faulker, who is also a Bison. Full disclosure, she and I were Bison together starting. So she has her doctorate in pharmacy. She is a pharmacy scientist and patient concierge or navigation specialist. She has a lifelong navigation experience, and she has worked with patients as they manage various cancer diagnoses and terminal conditions. Welcome, Dr. Faulkner. Very happy to have you this evening.
Great. Well, you know what? I'm going to start off with Dr. Laiyemo, who we already talked about has this focus on colorectal cancer research. Can you tell us a little bit about why did you choose colorectal cancer research? Why is it important to you?
That's actually a great question. The way I like to tell people is I actually wanted to be 6 feet tall, handsome, and rich. But that's still a work in progress. So when I did my gastroenterology fellowship, I decided with the advice of my mentors to actually go for the Cancer Prevention Fellowship program at the NIH. So one of the things that became obvious to me earlier on is that I actually didn't like cancer at all, and I hate to hear cancer diagnosis. So that's why I was advised that if you want to actually do something about it, why not just go into cancer prevention? So that's why I went for the fellowship. So, and of course, I like to joke, even though it is serious, that my heart is actually in the colon. So, it was just a natural fit that since this is part of what I really do, and this is my area of research, that what can we do to ensure that no colon is actually left behind? So that's really the theme that drives my research, and that's what I've been doing.
I love that. No colon left behind. So tell us, is there a difference between colorectal cancer and colon cancer?
More often than not, we use those terms interchangeably. When we say colon cancer, we are referring to the portion of the colon that's actually beyond the rectum. But because sometimes people in epidemiology analysis want to say that the rectal cancer is a little bit different, but by and large, it's essentially the same thing. So people can use them interchangeably when we talk that colorectal cancer or colon cancer. We're still kind of referring to the same thing.
Got it.
That was one of my questions because I just never had clarity on that. Thank you for clarifying that, sir. Let's bring Dr. Faulkner into the conversation. Can you tell us what you do as a patient navigator, please?
Okay, absolutely. A patient navigator, in simple terms, is someone that helps you journey through your medical condition. Since we're talking about colorectal cancer, I'm going to relate it to cancer. So, say for instance, a patient navigator such as myself, and there are lots of them all around the country. Essentially, they work in outreach, starting with prevention, making sure people have adequate screening. And then with that screening, if there are any abnormal findings, making sure they have the appropriate testing they need. And if that is a diagnosis of cancer, then we help you to sort of decide, first of all, understanding what your disease is. And as I like to say, I like to make everyone an integral part of their own healthcare team. So we need to do what we can to help you through the process of prevention, or if there is disease, to treat that disease, tackle any barriers you may have, and we'd like to see you to survivorship. Unfortunately, sometimes it is end of life.
Thank you for making that clear. Dr. Laiyemo, I'd like to take it over to you if I could. Is there a reason that Black American populations, men and women, have a higher incidence of this type of cancer?
That's a great question. There are certain elements that want to suggest that maybe it's related to our body, our biology, our makeup. But research continues to show that if there's that difference, it's probably small as compared to social and implementation of an uptake of evidence-based process to actually reduce the chances of us getting cancer. What do I mean by that? We have studies upon studies showing that if African Americans get the same care and they get the same treatment as the Caucasian population, the risk of cancer actually goes down, and it approximates the same thing for everybody. So what then may be the reason? We do know that African Americans tends, and by this I mean people of African descent also, there's always it's not very common for people to want to discuss cancer diagnosis. And sometimes it's because people are not aware, and sometimes it's because they are scared to actually have that conversation take place. So if you don't know your family history, then you are not going to take the appropriate steps. And this is crucial because in families where they may have cancer, people in that family have a higher risk of cancer. So the conversation must take place. So if, let's take for example, and I'm going to use a practical example. Take in the case of somebody who has cancer diagnosis in the family, in the father or the mother at age 40. People in that family cannot wait to be 40 to be screened. They have to be screened 10 years earlier. So that means they have to be screened in their 30s. So if I'm to put it, I'm going to say, number one, the conversations that need to take place is not taking place as much as we want it to. And also people are not getting the care that they need or the screening that they need to actually mitigate this risk. Is when we take care of all those, then we can start thinking in terms of, is it biology?
Right.
So if somebody doesn't have health insurance, for example, that's the simplest one. And of course, the complex one at the same time, given our healthcare delivery system. If you don't have health insurance, you are not going to be screened because you can't go to the emergency room and say, hey, screen me, please.
Right. So I'm curious, is there a correlation between how we eat, so what we eat in the American diet, and colorectal cancer? And back to that question that Karen asked about the higher incidence of colon cancer in the Black community in the United States. How does that compare to colon cancer in Black people outside of the United States, for example, in different African countries, again, correlated to the difference in diet?
So studies have actually shown that those who eat a lot of fruits and vegetable type diet that the risk of colon cancer is actually lower. And those who eat a lot of red meat or processed meat, the risk of cancer is actually higher. So even though people sometimes want to say maybe it's because people live longer in the United States and maybe they don't live as long in, in say Africa, where the risk of colon cancer is actually lower. But if you do even age adjustment, you still see that difference. So it's not just because some people are living longer. No. But eating, the dietary pattern is not something that you change your diet last week and then you expect the effect to be today. This
Right.
is kind of a lifelong journey. So, but
Mhm.
studies has continued to show that those who eat more fruits, vegetables, and you know, uh, versus those who eat processed food, they tend to have healthier, lifestyle and colon and stuff like that.
Right. So again, those processed meats, stay away from those half smokes and hot dogs and bacon and pastrami, right? And
Right.
high meat diets, right, for
Right.
a healthier colon. Um, and then, Dr. Faulkner, what are specific examples of barriers that the African American community and sometimes others of color face in really getting access to cancer treatment? I think Dr. Layamo started talking about it, but maybe you can kind of flesh that out for us a little bit more.
Absolutely. And Dr. Layama, please add, because you did mention some of the barriers. One is fear. A lot of people just don't want to know.
That's right.
They may not have a clue, oh, that won't affect me. And as we know, knowledge is power. Um, Another barrier is language. Sometimes there's a language barrier in receiving care. Also, is a person going to be compliant? Are they actually going to keep their appointments? If you have a colonoscopy, which is one of the screening tests that you have, are you going to follow up, or does the office actually follow up with you regarding those results? That's one. Also, if you do have a diagnosis of colon cancer, are you going to actually accept treatment and then
Mhm.
be on a regimen to receive that treatment in a timely fashion? Are there barriers regarding employment? It's, I don't have time for this. It's a financial burden or barrier. Also, patient history, family history, not knowing your family history, like Dr. Lyoma talked about. Um, and
And
again,
that's not always possible, for example, if you're adopted, but, really sort of putting the jigsaw puzzle pieces together, like Dr. Layama was saying, if your parents had cancer, a colon cancer in their 40s or even 50s, you need to start getting screened even younger than that.
absolutely. And maybe Dr. Layama may discuss this. Now there are ways of determining a genetic component. If you don't know your family history, there is
Mhm.
also that option. So those are just some. And it's a matter of, okay, if chemotherapy is scheduled for, let's just say Monday, Wednesday, Friday, well, how am I going to get there? Is there an issue of transportation? And you'll see in my talk that we try to make sure we do everything we can to make sure that you receive the treatment that you need, whether it's transportation, whether it's care for young children, or if you are involved in elder care responsibilities, making sure that your support system is taken care of as well as you.
Can patient navigators help with any of those barriers?
Absolutely, they can. Now, every cancer center is different. Sometimes people receive these diagnoses in a private practice setting. So patient navigators are different. Some cancer centers have their own team of people that this is what they do, whether it's one person or multiple people that take care of every aspect, whether it's financial, treatment, resources, um, all those things are taken care of by maybe a group of people. Sometimes it's outsourced through the American Cancer Society or the National Cancer Institute. Since we're talking about colorectal cancer, the Colorectal Cancer Alliance also is a wealth of information and their sources. There's also private funding. If people have a fear of, well, I don't have insurance, um, there there are funds available, whether it's private funding, or actual funding through um, HRSA, I think, which is the Health Resources Services Administration. There are ways of making sure that you receive what you need in a timely fashion.
That's great to know. Absolutely.
I'm really glad that we had you on the show. It's like you have to work hand in hand with these providers. It's a team effort, isn't it?
Yes, it is. And the patient navigator is just one part. Some people refer to us as patient advocates. Some centers have case managers, or social workers. There's so many different names, but we all have the same common goal, is to make sure that the patient receives what they need in order to go through the
Mhm.
process of having treatment. And unfortunately, sometimes there are even clinical trials. You may be eligible for a clinical trial. And again, your centers would know about these things. But again, we all work together as a team around the person. So anything, ask whatever you need. If I or someone like myself isn't able to help you, we can find those resources or people to help.
That's great to know.
Thank you so much for that. I want to take it back to Dr. Layamo, and this is a painful question to ask because just in the past 5 years, I've lost two very close friends to this horrible disease. Of course, you mentioned the other well-known folk, Chadwick Boseman. They were very young. Why is this happening to people so young? Can you tell us a little bit about that? Has there been research?
That's a big elephant in the room that we don't know the answer to, and that's why a lot of research is being done now, in terms of trying to figure out, like Dr. Mel mentioned at the beginning, that you see improvements in those who are older, but then you see an uptake of colon cancer among those who are younger. So one of the things that it's actually difficult to actually tease out in terms of the real causes of this. But one thing that we do know is that when people present with symptoms in the past, we used to just say, if say, let's say, for example, somebody presents with bleeding, sees blood in the stool. For young persons in the past, we used to think, well, maybe this is just coming from hemorrhoid or pile, as they say, or dysentery or something like that. But we do realize that many a time young people also, when they have symptoms, they tend to just say this is nothing. By the time they are presenting to their doctor for evaluation, many a time it has gone far. So, so in terms of strategy, it is don't ignore any symptoms. You know your body better. If you are losing weight that you can't account for, you are seeing blood in your stool, or your bowel habit is changing, don't ignore that you are only 35 years old. Don't ignore it, because it may be symptoms of something greater. As per to be able to say maybe it is this one cause, we really don't know. And the challenge with younger people who are younger than 50, before the recent change in recommendation, is that this population is not screened. Okay,
Mm.
screening in the past was from 50 and older. In African Americans, it's recommended to be screened from 45. That's a while back. But American Cancer Society in 2018 now said everybody should be screened from age 45, even though in terms of the overall yield is lower, but there's benefit in it in people being screened earlier, given the uptick or increase in colon cancer among young population. So if there's anything to take away from this, it is number one, discuss with your family members. Because those who have family members, especially at young ages with colon cancer, they still have a higher risk of colon cancer. It always breaks my heart anytime I see somebody whose father or mother had colon cancer and they are showing up in their 50s and 60s for the first time for colon cancer
Right.
screening. It shows the information is not there. I mean, and it's not good, because regardless of who has colon cancer, if it's your first degree relative, screening should start either at age 40 or 10 years earlier than the index case. So if somebody, say the mother had colon cancer at age 65, screening should still begin at 40. It's just the modality that will be different. If somebody is now at 45 that they are diagnosed with colon cancer screening should start at 35, 10 years earlier. So it is either 10 years earlier or at age 40, depending on what is earlier. See, so that's the key part.
So
So
when
that
you say, just to be clear, when you say index case, you're talking about the person in the family who had it before.
exactly, yes.
Okay.
That would be the
So
next. Yeah.
when would this
And the-
conversation come up? Like when the doctor interviews a patient about their medical history?
I think we should start it from the family. You know, like charity that they said begins at home. The
Mhm.
colon cancer conversation should begin at home. If
Okay.
anybody is diagnosed with colon cancer in the family, let the family members know. That way they don't wait till their next doctor's appointment. And we know colon cancer is highest among black men. And in case my background is not showing well, you can tell I'm a black man too, right? So there are certain conversations we don't like to have, but many a time he may not even want to go to the hospital until the wife like pushes him there or drags him there or something. So if the conversation is not taking place at home, the charity is not beginning at home in terms of the conversation, you can actually tell your doctor that, oh, I have a change in my family history. So person has just been diagnosed, and that changes the trajectory of what your primary doctor would do. So anytime you go to your doctor, if there's a change in your family history, discuss it with your doctor because the trajectory of your care may change.
Right.
think
I think that's an excellent point. It isn't always that our doctors are going to be proactive, right? We also have to put the pieces together and know if there's a family history, we need to let our healthcare providers know. We've talked a lot about screening. What is screening? What does that entail? What does it mean?
That's great because there are many things we hope will work, but what we do know is screening works, especially in the case of colon cancer. So screening is when you are looking for a disease before it manifests itself. So in essence, you are trying to find either something that is precursor, that is the formative stage of it, so that the cancer does not develop at all. Okay, so that will be screening. Or you want to do what we call early diagnosis or early detection before the cancer manifests itself. So both both sides are really good because if you are, and we do know colon cancer develops from bumps in the colon that we call polyps. So if we remove those polyps, more often than not, they don't become cancer in the future. That person will not develop cancer in the future. Although sometimes they still do, but you have reduced the trajectory of them developing cancer significantly. However, if when you are even screening, you end up diagnosing the person with cancer, those cancer tend to be diagnosed in early stages when cure is still very possible. Okay, cure is still very possible if colon cancer is diagnosed at a very early age. So it makes it like the ideal screening, ideal screen disease for which screening is very effective. And studies upon studies have shown this, that when people get
So
screened, they can reduce their chances of dying from the disease.
So when we say screening, though, are we talking about a colonoscopy only, where they take the little lighted tube and they put it in your rectum and you're asleep and it snakes up through your colon and they take pictures and look? Is that the only way of screening, or are there other kinds of screening out there?
I love the way you said snake it through. It's like
Snake
the
it up
plumber
there,
moving,
like plumbing, like a plumber. Yeah.
Right.
trying to move stuff out, which is a great description. I think I'll keep that in my mind.
Sure, you can
So,
have it.
so
Yeah.
there are multiple ways of actually screening. So you have ones that are stool based. So you have that they will check the stool for blood. They tend to do that one every year. They call it either the occult blood test or immunochemical test. Is still essentially the same thing that you are looking for changes in the stool that can be signs that you're having changes in your colon that may develop into cancer, or you're having early stage cancer. So you can
that's
have
when the doctor gives you the little card and you take a little
so
some
they
of your
give you
stool and you
card and you
yeah.
and then you also have one that the company they call it fits
Card.
DNA, and they call it ColoGuard by the company that makes it, in which you actually take care of your business and then you ship the stool out. And then it sounds interesting when you think about it that way, but it does work because then they check the stool to see if there's any abnormality in it. Then, of course, you also have flexible sigmoidoscopy, which is not often done these days. But then colonoscopy is the one that actually, like the one Dr. MEL described, that you clean your bowels and then they use the video camera when you are asleep so that you are very comfortable during the test. And they look in the colon looking for polyps or anything that may happen. Of importance is why you have colonoscopy being talked about is because if you have any abnormality from other tests, then you need colonoscopy to complete the process of screening. So the message is whichever one you want to do is fine, but make sure you complete the process of screening. So if you do stool test and then the stool test is positive, don't sit on it, okay? Because like I said, we don't want any
No
colon to be
intended.
left behind. So if you get a positive stool test, then go get a colonoscopy to complete the process of screening.
That
But
makes sense.
colonoscopy can do both initial diagnosis and the screening process and removing polyps at the same time. That's why we like to call it the one-stop shop.
That
Great.
makes a lot of sense. Now, I want to just kind of go backward a little bit because we were talking about it before, but I want to make sure that I have this straight because you brought in another point, Dr. Laiyemo. What are the signs that people should be looking out for that would get them to start having this conversation about, I need to look a little bit more closely at this? You talked about changes in the stool. You talked about bowel, difference in your bowel habits. Is there anything else that
Okay,
people
so
should be, can you
yeah,
name
that's
maybe
a great
4 or
question.
5?
The number one thing is as you are getting older, because the number one predictor of people getting cancer is aging. And not too long ago, I used to tell people I'm getting older, and the guy told me, he said, well, getting old is a privilege not given to all. And I'm like, wow, I can't even floor that statement. So
It's true.
it's
It is
true,
true.
because getting old is a privilege not given to all. So as we get older, the chances of getting cancer increases. So even if you have no symptom and you are 45, you should begin screening. So that would be number one. And then for those who are younger, okay, because once you begin the process of screening, you're already in the system to protect your colon from colon cancer. But for those who are younger or at any point in time, if you notice you are seeing blood in your stool, okay, don't just ignore it that maybe it's just hemorrhoid. Don't do that. Don't assume. I mean, in my Yoruba background, there's an entity they call Jedi, which nobody can really explain what that means. They put everything in it, whether it is blood in stool, whether a man that cannot do 12 rounds overnight, they put everything in it and they call it the same thing. So everybody has some problems in terms of defining what will tilt you over. But blood in stool, changes in your bowel habit, losing weight when you can't explain it, or having anemia, or you are told that your blood count is low, especially for a man. Okay, because a man, we know men don't lose blood, right? So if you are, they don't lose blood in a monthly cycle, right? So if a
Understood.
man is having iron deficiency anemia, they're taking your blood count is low, it has to be investigated why are you losing blood. So these are the general things that are very important in terms of understanding if one is developing colon cancer, and then should see the doctor for appropriate evaluation.
Thank you. That is a great rundown, Dr. Laiyemo. And just also to add around the change in your bowel habits. So, like if the appearance of your stool you know, gets narrow, right? If the actual look of what your stool is shaped, the shape of your stool changes, that's also included. So, Dr. Faulkner, what happens when a patient finds out, they're gone through this process, they've been screened, they get the unfortunate news that they have this cancer diagnosis? How do you become part of the team? Are you assigned to somebody, or does a patient or family have to reach out and request you? How does that work?
Well, there are multiple avenues to finding colleagues like me. One is, like I said, most cancer centers have a patient navigation program. So there's someone that becomes a part of your support system. In the case of me or colleagues like me, oftentimes it could be word of mouth. It could be that you are signed. If you're affiliated with a company, they're patient advocacy companies. And then in instances for me, it's people that I've known that I've just taken it on to help them through the process. There's some that are paid out of pocket. Some are covered by insurance. It just depends on a lot of different standards. But the first thing is, let's just say someone has the unfortunate news of having a diagnosis of colon cancer or colorectal cancer. You want to make sure that the patient understands that, listen, do you understand your disease? There, and Dr. Loyola can say this, there are positives and there are negatives. What are the pros and cons? What are your treatment options? You decide again to make sure that a patient is informed and they make a decision that works best for them. And then we as a team, whether it's the gastroenterologist, Dr. here, your primary care physician, internal medicine, the oncologist, if it's surgery, all these people get together. And again, when you're informed of this, then you make the decision that works best for you and how
And
you want to.
should people seek out cancer centers that have patient navigators? So even if they might be diagnosed at one place, actually seek out, uh, hospitals that have a patient navigation program?
Well, it's kind of up to the person once you inform them. Like I said, some centers have it, others may not, but that's when the American Cancer Society is an integral part during this process. They're actually available 24/7. There's a 1-800 number for them that you can call. They have folks that'll help you. Now, again, navigators, we can't give medical advice, but we can provide the resources and kind of help you through, whether it's a person that survived, that's a survivor, they may be able to and tell you what their experiences were like. They're financial navigators. They're, again, patients that are survivors, or those who have lost family members to the disease may also be a part of your support system. A couple other agencies I'd like to talk about, and I had permission to disclose the names of those companies. There's the Greater Advocacy Network. There's American Cancer Society, National Cancer Institute, Cancer Information Services, like I said, the Colorectal Cancer Alliance. There's also a company called Patient Navigator, LLC, the National Association of Healthcare Advocacy. The OMA Foundation is a foundation here in the Washington, D.C. area that works specifically with young adults with cancer.
Okay.
Of course, there's the City of Hope. I mean, there's so many all around.
Okay. Well, that's good to know. That's good to know. Thank you. And then, Dr.
Absolutely.
Loiyemo, we talked about genetic testing earlier. Actually, Dr. Faulkner mentioned it. Is there genetic testing that can determine whether a person has a possibility of colorectal cancer sort of in advance?
Some of those, that's a great question, but it's an evolving field. Some of
Mhm.
those things is still like trying to look for something really tiny. Um, there are certain things that we do know that are associated with increasing genetic propensity to develop colon cancer. For example, if you have familial adenomatous polyposis, if they find that in your genes. But for the as a screening for the general population, it won't be advisable because you're just going to have so many things that you won't be able to interpret. But the
Okay.
easiest one to start with is actually talking with your family, which does not even cost anything except a phone call.
Right. Right.
So that would be the initial starting point, rather than going the route of trying to find everything in your genes, which will just scare everybody, make everybody go bonkers. So
Okay. All right.
Yes.
You were going to say
y-
something, Dr. Faulkner?
Yeah, question I have is what about people go to Dr. Google all the time? You as a gastroenterologist and specifically related to your research in colorectal cancer, what about advertisements for virtual colonoscopy? Do you have any expertise regarding those? Do they actually detect if there is an abnormality in your large intestine?
okay, so what they typically will call virtual colonoscopy is CT colonography. That is, they'll do a CT scan. The patient will still drink laxative to clean the bowel, and then they will
Okay.
do CAT scan, and then they will do the 3D image, so that when you are looking at it, it will be as if you are doing a colonoscopy. So it's one of those tests that you can do. However, if you have a polyp or a precursor lesion, you still need colonoscopy for that. It's one of those recommended screening tests, but it's not widespread done, because one of the things that discourage people the most is because of the laxative they have to drink for colonoscopy. So if you have to
Right.
drink the laxative for this test, and then you are still going to get, exposure to CT scan, but then if they find a polyp or something, then you still need to go and get colonoscopy itself to get
And
it
you got to
removed. So
you got
that's
to
the
take a dose. Yeah. So I think we need to bring Lila and Wayne back into the studio to see if we have any questions from the audience. Lila and Wayne, come on back and join us.
Oh, hello. There we are.
There we are.
Hey,
We're back.
what do you have from us or for us from the internet land?
From people in the streets and the interwebs. Let's see here.
Right.
You have some, Wayne?
Yeah, I do. I have
Okay.
a from Dead E. I believe that's what they're saying. Is there any evidence showing gay men have higher risk or rates of colon cancers or tumors than straight men or straight women?
There's no, I'm not aware of anything that has shown that. But anything that they are at risk for, being human beings, getting older, and having any symptoms will still apply. So your sexual orientation has little or nothing to do with your risk of colon cancer.
Mhm.
Yeah, nothing that I am aware of that increases the risk.
All right.
Okay. I
What
have
else?
more.
However, that said, for in terms of the anal, because we are talking colorectal, okay,
Mhm.
so anal may be a little bit different because that's not classified as colorectal. Because those who are, you know, uh, gay may have more propensity for anal because of infection, HPV and stuff like that. They may have more propensity for that, but that's not necessarily for colon cancer. So the regardless of who you are, if you notice blood in your stool or you have a change in your bowel habit, you should still get it evaluated, regardless of your sexual orientation.
Good point. Thank you.
Thank you for
There
making
you have
that
it.
difference.
Lie.
More of a statement from Annette Van Ginkel. My son is 25 years old. His dad died. Um, my youngest son has the gene too. The gene she's speaking of is the Lynch syndrome. Did we? Did we
Okay.
address that at all? And I want to sort of piggyback on that. I was saying this to our producer off camera. I was a caregiver to my cousin who had colorectal cancer back in 2013, and that was called, it was something that ran in the mails. Jaeger, I believe, is what,
Jaeger.
how do you pronounce it, doctor?
Who's Jaeger?
Jaeger. And so I'm just saying this and that. I think back to everything everyone has said is, especially when there are these propensities for it to be hereditary, screenings are the way to go. Early screenings, especially when we know there have been these issues in our families. Outside of screenings, what else can we do to sort of as a preventive measure?
I'm glad you actually brought some of these genetic ones that are established. So the percentage that actually is genetically linked is actually very small. It's less than 5% of all colon cancer. So,
Interesting.
but those who have them, they have very high risk. So, take for example, if somebody has what we call familial adenomatous polyposis, so that's a genetic disorder in which the people who have this disorder are likely to get colon cancer before they even turn 45. Okay, they are likely. So, and it runs in family for those who inherit it. So much that the in that family, the first degree relative, they don't wait till they are even in their 20s. No, they start screening them when they are 12 years old, preteen.
Wow.
So because that one, it has a very high, almost 100% that whoever has it will develop colon cancer. So they start screening them from age 12. You look in the colon, if you see polyps already at age 12, you know this person is going to develop colon cancer. So they are treated differently. For Lynch syndrome, which Leila talked about, that one we actually start screening them when they are 20 years old. So the screening in that family, you don't wait till they are 30 or 40. That's why I was emphasizing discussing with your family,
Right.
having that family discussion, because everything still begins with that. For those who have Lynch syndrome, you start screening them from age 20 years of age. The way we do that is you get colonoscopy from age 20, every 2 years until they turn 40, and they get colonoscopy every year. So the way to look at that is 20 times 2 is equal to 40 times 1. So
Mm.
every 2 years from age 20 till you are 40, and then every year thereafter. So these are the ones that are known to actually have a very high risk in those family. But thankfully, it accounts for only a very small percentage. But for the majority of the people, we really don't know exactly why people develop colon cancer. And that's why we call it the sporadic type. And that accounts for about three quarters. Okay. So about three quarters. So if you are breaking it down, the ones that will be due to genes or having inflammation in your colon, like Crohn's disease, ulcerative colitis, and including having the FAPs, the Lynch, all those FAP, Lynch, and all those will account for maybe about 5%. When you have family history, somebody in the family, father, mother, have colon cancer, the increase in that group will be about maybe 20%. And then
Right.
the 75 is sporadic, which will be anybody. So
Right. So for those anybody people that it's not genetically linked, what would you say your top 3 preventive actions that they can take? We talked about plant-based diets, anything else that people should be thinking about in terms of preventing
number
actions that they
one,
can do?
number one is to get screened age appropriate. Age and risk appropriate, which means it's going to be different for everybody. If there's no family history, then from age 45, ensure you get screened. Okay, whichever one you choose is fine. Still get screened and complete the process of screening. So
Right.
age, number one. Number two is to have a healthy lifestyle. If you smoking is known to increase the risk of colon cancer, cigarette smoking is known to increase. Alcohol is known to increase the risk. Maintaining adequate healthy body weight, it has been shown to decrease the risk. So, and then of course, those who have sedentary lifestyle, those who don't exercise and all that, they have increased risk, which means those who are actually very active people, they have reduced risk. And of all the things you can even think of, that's actually the cheapest, to be active. That's
Yeah.
the one that's available to everybody. You don't need any government, you don't need health insurance to exercise. Okay, so those are some of the things we can do apart from eating healthy and then making sure if you notice a change, you get it addressed early.
Yeah. They say sitting is the new smoking in terms
Yeah.
of cancer risk.
Yep.
So just get up and move. Get up and move around. It doesn't even have to be heavy duty exercise. Just move. Don't sit.
Listen, I'm on this kick. I am doing these line dances from TikTok, and I'm closing these exercise rings just from that. You can
There
make
you
it.
go.
Like,
There you
close
go.
those rings, Lila.
Wayne,
Do we
you
have
All
any
right.
other questions from internet land?
So we have a couple questions. One is for Dr. Faulkner. Do patients have to pay, or is your work covered by health insurance or other sources?
For patient navigators, in some instances, it's covered through, it's a part of your cancer care, since we're talking about cancer. In some instances, families choose to hire a private duty person to help them through the process. So it just depends. However, in most instances, like say for instance here in Washington D.C., we have the Ralph Lauren Cancer Center for Prevention. That is a part of Georgetown Lombardi Comprehensive Cancer Center. Uh, we didn't talk about Dr. Harold Freeman, but if any of you ever do a Google search of Dr. Harold P. Freeman and his oral history, he talks about how he developed this program. He's a Black physician. He worked in Harlem Hospital, and he noticed back in the 1980s, why is everybody coming with breast cancer and it's so far advanced and they're not getting screening? So he was able, as when he was president of a cancer organization, the American Society of Clinical Oncology, he was able to approach the president of the United States and talk about the need for care for the poor. So there has been funding since around the year 2000, although his program started back in Harlem in 1990. So there's funding around throughout the country. So it's not always a financial burden to someone with cancer. There are ways for them to receive the care they need, and they don't have to come out of pocket for that. In some
Is
instances, just say, if you're having cancer care, I know someone had prostate cancer, they were offered meals. Healthy choice meals based on their diet preferences. Someone that's vegetarian, they offer them culturally sensitive meals. Some instances, a person may need a gas card for gasoline or transportation, like a Uber or Lyft. All those things are available, whether it's through public funding or private funding. So in most cases, you don't have to pay.
what about
I'm really glad
Medicare?
that you I was just going to say, I'm really glad that you mentioned that because a lot of people don't realize that there's a trend now in healthcare to help people take care of those social needs that
Right.
prevent them and
Mhm.
are barriers to them getting better. So things like gas cards, things like transportation, housing, and having a safe place to know that you can lay your head reliably every night, food
Mhm.
and healthy meals, all those things now sometimes are being covered by Medicare, by Medicaid,
Mhm.
or special programs that the hospital might have or be able to direct you to. So thank you so much for bringing that out. Do we have time for
Exactly.
We
one more
got time
question?
for one more question. And that
Okay.
All right.
question is for Doc, and this is lightning round, so we got to be brief. So,
Okay.
what is the survival rate once someone receives the diagnosis?
For Dr.
So
Liamo.
my
Yeah.
my my preference for the person, if the person is diagnosed with cancer, is to be diagnosed at the early stage with screening, in which case the survival is like 94% in 5 years. So
Mhm.
that's the figure I want you to keep in mind. If your cancer is diagnosed at the very early stage, 95% survival in 5 years. The flip side, if it's diagnosed in stage 4 when it's metastasized, that it has already spread, is less than 12%. It's like 11% or thereabout in 5 years. So you see the big difference. So that's why the emphasis is on screening to prevent and or make early diagnosis so that the survival in 5 years is still about 90 something percent.
Excellent.
Excellent.
That's what we
Um,
need to hear.
if I may add, Karen, you asked about Medicare and Medicaid as far as covering. There's been legislation that's been passed with the Biden administration regarding Medicare. So
Mhm.
there are companies that do provide patient navigation services, and those are reimbursed through Medicare for the patient navigator. That is available. And some states also have programs like Dr. Clark stated through Medicaid. So
Mm-hmm.
again, please don't feel that your care that there's a financial burden because there are resources available for folks. Okay.
Right.
Right.
It's good last
So those
word.
are some, that's a great note to leave off on. Early detection, great survival, and there are resources available, and talk to your family. Those those are like the key pieces I think that we have taken away
Yep.
from today. You all have been fantastic. Thank you so much, Dr. Laiyemo. Thank you so much, Dr. Faulkner,
Pleasure.
for giving us all this great information to work with. Of course, thank you, Karen, for joining us again. Always a pleasure. And Talila and Wayne, can't do it without y'all. Thank you so much for being here. My Be Health Empowered family, you got great questions each and every week. Thank you so much for tuning in. And remember, until I see you again, be wise, be well, and be health empowered. Thanks so much for joining.